Hello, my name is Christian Barton. Welcome to this presentation on translating research into clinical practice. A couple of quick disclosures. I'm a physiotherapist, so very biased towards exercise therapy and education as management for persistent musculoskeletal pain conditions, which is what I practice in. I also teach courses related to running and knee injury management and associated with not-for-profit initiatives including GLAD Australia and TREC, which we'll talk a little bit about in today's presentation and subsequent ones for the conference. I'm also a deputy editor for social media at the British Journal of Sports Medicine. So today we're going to cover a few topics. We're going to ask the question, what do guidelines recommend? What are the guideline practice barriers? What changes practice? So how do we actually change clinical practice? What is the impact of physiotherapist training on osteoarthritis in Australia? And what is the key ongoing barrier? So what is guideline recommended care for osteoarthritis? With a program that we run in Australia, GLAD Australia, we've adopted a model where we consider first line, second line and third line care. So based on compelling evidence, first line care should include patient education, exercise therapy and weight control for hip and knee osteoarthritis. We can also consider second line care. So some of these things might be pharmacological pain relief, might also be consideration to passive treatments and gait aids, injection therapies, etc. And third line care, which would be provided to very few, would be surgery, and in particular joint replacement surgery, which can be high value care for those who truly do need it and have appropriately trialled first line or second line. So if we look to the Australian context, all people should be offered exercise as first line care. And looking at the RACGP guidelines, the recommendation is we strongly recommend offering land-based exercise for all people with knee and hip osteoarthritis to improve pain and function regardless of their age, structural disease severity, functional status or pain levels. Now the type of land-based exercise that could be provided can vary quite significantly in clinical practice, and in reality some exercise is going to be better than none. So on a positive note, we have many different options which might be able to help. The problem we face though is how many people actually access land-based exercise therapy. So one of the things to consider is if we look at what beliefs of doctors might be, and in a recent qualitative study led by Jason Wallace talking to doctors particularly in the private healthcare setting, these were some quotes from surgeons and quote from a GP. I mean, if the x-ray is really bad and showing bone on bone, I don't think physio is going to really be able to do very much except keep the muscle strong, and then joint replacement must be considered. So there's almost this pathoanatomical focus and defeatist type consideration that maybe exercise can't achieve what we hope it can achieve, coming from doctors who might refer patients on to receive support, maybe seeing a physiotherapist or an exercise physiologist. This translates across to patient beliefs as well. So from a patient, I've been told that I've got bone on bone and I need a new knee. Another patient, I've had 3 arthroscopies and meniscus tears, but along that way it was explained to me I have very little articular cartilage in both knees, so I was expecting that it's going to be a problem. So what happens is that our population with osteoarthritis starts to have this belief that maybe exercise can't help them, but that's not true. We know regardless of radiographic severity, structural changes, that exercise can be a really powerful tool for us to use in clinical practice. So if we go to what GPs do within our clinical practice setting, and this is the latest update from the BEACH dataset, so paper from Kim Burnell and co from University of Melbourne, and when we look at GP referral patterns for osteoarthritis and hip and knee osteoarthritis, what we see is around 25 to 31% of patients are referred for imaging, so X-ray or MRI. In fact, this is around 1 in 2 are referred for imaging at immediate consultation. This is despite the fact that we really don't need imaging for most people unless we're considering surgery. Certainly shouldn't be part of first line care and can often send people down that pathoanatomical pathway. Of course, if we want to rule things out like red flags, we should consider image, but the vast majority of people probably don't need imaging. So if we look at surgical referral, what we see is between 13 and 16% of people with osteoarthritis are referred for surgical opinion. If we look at second line care, this is a data set related to opioids, which we know are harmful in many cases. Yet around 15 to 26% of people are referred or recommended and prescribed. There's also similarly high rates for for pharmacological treatments like NSAIDs and paracetamol as well. If we look at first-line care and referral from a GP setting, this is where the rubber really hits the road and gets quite interesting. We see just 5% are referred to see a physiotherapist. This is a slight increase on earlier data, which was around 3%. If we look at things like dietitians, then actually we're well below 1%, and EPs, it's almost negligible how many are referred for this. So we're seeing very few people within Australian clinical practice in a primary care setting being referred for first-line care, and this creates a big evidence practice or big guideline practice gap. So one of the questions I ask as a physiotherapist is, what are my colleagues and what am I providing and what should we be providing? And I think the important thing to note is that there are many different options that a physiotherapist can provide. So when I talk to GPs and I talk to others about why they may not refer, there's many different factors. One of the things comes out in some of our research and informal conversations is they don't always trust what they're referring for. So they may refer someone for physiotherapy, but in fact, when they get there, instead of receiving high quality education and exercise, they're receiving ultrasound, maybe dry needling, maybe massage and soft tissue therapy. All these things might be helpful for the patient in the short term, but we know longer term that's not going to be all that beneficial. And what we should be providing as physiotherapists should be first line care, including patient education and exercise therapy. So this big guideline practice gap, at least within our profession, is quite strong. So one of the pieces of work we've done is this is a survey which is unpublished data, but hopefully will be published soon, looking at different beliefs of physiotherapists in Australia. This is a data set of more than 1,000. We asked them a whole range of questions related to the combi model, so capability, opportunity, and also motivation. And if we summarize some key findings from this, what you'll see is that a lot of physiotherapists, in fact nearly half, or at least a third, would suggest that they don't have the organizational support in order to deliver people education and exercise therapy. So that might be short consultation times, they may not have the necessary rooms and exercise equipment to deliver this type of care. If we also look at training, we see that the majority of physiotherapists do not feel they've been trained to follow current clinical practice guidelines, and confidence with the unmotivated patient is also typically quite low. So we have this evidence practice divide or guideline practice divide driven by organizational factors, but also factors that we can possibly change around training of our physiotherapists and also providing quality education and support for them to implement programs that might provide high quality patient education and exercise. What's important to note is if we look at guidelines, we know that they're often limited in providing how-to guidance. In fact, among our cohort of more than 1,000 physiotherapists in Australia, just 11% are able to name an accepted guideline. So if I think about what I spend most of my time as a researcher doing, it's based around this current journal model, and what we look at doing is publishing our paper. So we complete our research, we develop questions, and we design our research, we complete our research study, and then we analyze the results. We then go on to write a manuscript, we submit it to a journal, hopefully one journal, but often it could be up to 6 or 7, or our record I think in our team is up to about 9. We get it peer reviewed, we address concerns, and then we finally finalize the paper. We sign over our copyright. So let's say this is a study, an RCT, that's showing that exercise therapy and education might be beneficial compared to usual care in Australian clinical practice. And then actually it's really hard for people to then read it. Clinicians don't understand it, and it rarely translates into clinical practice. So one of the things that I've been really interested in the last few years has been, well, what can we use to try and help change practice? So this is a large survey actually from around about 1,600 physios from all around the world. About 400 of these were Australians. And we actually asked them the simple question of, you've got this list of options for learning, what would your preference be? And what you'll notice is green is their most preferred resource all the way through to a ready color, which is least preferred. And first thing you'll notice is huge variation across all the different options, from workshops, original research articles, podcasts, webinars, videos, infographics, and also blogs. So there's some people who will prefer a blog, other people will prefer infographics, other people prefer videos and webinars, others podcasts. But the thing you'll note is the vast majority of people will actually have a preference for workshops in terms of trying to improve their learning and understanding of how to manage conditions. And importantly, it's workshops that is an active learning process that's probably capable of also changing practice. So when we think about how can we address evidence practice gaps, then workshops are going to be a really important part of that. So one of the other simple surveys I was involved with around the world, facilitated through professional societies and 1,000 or a little over 2,000 sports and musculoskeletal physios, and we asked them, what was the source of your most recent change in clinical practice? And we asked them questions and options related to attending a course, talking to colleagues, postgraduate university training, reading research papers, podcasts, a whole range of different options. So what is it that actually led you to change your clinical practice, adopt a new technique or a new treatment strategy? So if we just summarize a couple of brief things, back to the concept of journal articles maybe not being all that useful, 1 in 4 that had a PhD who answered this survey would suggest that a journal article is the most recent thing that caused them to change their practice. But if we look at the whole population we had of more than 2,000, just 1 in 10 suggested a journal article changed their practice. So just highlighting that journals are unlikely to assist. What we typically found was that private courses and peers were the key changes, and actually that made up more than 50%. So 1 in 2 people in most recent change their clinical practice come from a private course or from conversations and teaching with their peers. So this tells us these are the types of things we need to consider if we're going to bridge guideline practice divides that we can see. So we've further explored this with a whole range of physiotherapists in both Australia and Canada, and in particular focused around persistent knee pain and osteoarthritis. And those who are interested can obviously go and read this paper. There was a lot of information around knowledge and confidence, but we also explored learning needs. And this was a mixed method study where we did both survey, but also quite detailed semi-structured interviews with 13 of the participants in this study. And what came out was there's a really strong emphasis on face-to-face learning being a key thing to trying to change clinical practice and embed new treatments. So definitely courses are the best way because you get an interaction between other therapists, you get hands-on, there's usually some application to that active learning approach. I'll talk more about this later in the week around online and digital resources for facilitating knowledge translation, but in particular they were seen as helpful, spreading knowledge and being convenient, but typically people preferred face-to-face learning if they're actually going to embed and to change practice. And so that's a really important consideration for us if we're going to try to address the guideline to practice divide. So the next thing that we embarked on, this was back in 2016 and collected a lot of the data I've just presented now before then, despite it being published a little late. That shows you a bit of a lag in our publication system. But we decided to work with a group of Danish researchers to implement a program called GLAD, Good Living with Osteoarthritis from Denmark. And the program is quite interesting and quite unique in that it actually does facilitate data collection and patient outcomes. So if we give a summary of what GLAD is, there's 3 core elements. The first element is providing physiotherapist education, training and support. So we provide courses and workshops and practical learning. We also provide additional support to facilitate implementation in various different settings, public and private. The second part is those physiotherapists go back and they deliver GLAD as intended. So the program involves 2 patient education sessions and then also 12 group exercise sessions. It's really important that that's delivered as a minimal intervention, but what's also important is it's focused around goal setting and tailored to patient needs. So it's an individualized program, and the program can be added to as required. So if additional exercise components are needed or additional first and or second line care strategies are required, it's okay for the physiotherapist to provide that. We then provide a process to collect data and collect patient outcomes using an online platform. And this has been a really key and important part of the program. So just briefly, the patient education, we try and address some of those misbeliefs around that pathoanatomical focus and try and open up the person's perception that there are many different factors, both physical and non-physical factors that might link to pain and disability. And importantly, it then makes sense that education, understanding and exercise is a really key focus that we can work on to try and improve outcomes. We talk about different forms of exercise and break down beliefs and perceptions around the difference between physical activity and therapeutic exercise. So therapeutic exercise being exercise we provide as physiotherapists that focus on specific joint control, functional capacity, muscle capacity, We can also look at things like flexibility and aerobic exercise. And importantly, we talk about the benefits of exercise to the structure of the joint. So the fact that we need exercise in order to stimulate a turnover of synovial fluid and bringing nutrients into the joint cartilage. This is a really important concept for patients to understand. Exercise is not necessarily harmful for the joint, it can actually be quite beneficial. So that's a key focus of education. And then the exercise program itself focuses on neuromuscular exercise. And just to show you a brief little video of the exercise program, and you can see that there's a web link there which you can explore beyond this session and look at a lot of different exercise components related to the program.
Stand weight bearing on one leg with the other leg on a sliding surface. Slide backwards to forwards with the sliding leg whilst flexing and extending the knee of the weight bearing leg. Ensure you are keeping good alignment of the shoulder, hip, knee and foot. To perform this on carpet, you may use a slide pad, which can be purchased from your physiotherapist. To progress this exercise, you can reduce the amount of upper limb support, increase the repetitions, increase the speed of the movement, or take a longer slide. If you find your knee falling inside of the foot, it helps to contract your hip muscles to rotate the knee outwards.
So as part of the implementation process, we have many different resources like this to help patients and help physiotherapists implement the program. We have many education resources as well, from PowerPoint slide decks to patient handouts and a whole range of things. And this has been vital to successful implementation of GLAD in Australia and all around the world for that matter. So we now have GLAD embedded in clinical practice across more than 400 sites in Australia. And this has been a big effort, and there's only 6 faces up there. You'll see Professor Eva Roos and Soren Skoo, who supported us to implement the program in Australia. Professor Kay Crosley, who's been a mentor of mine for a long time and very instrumental in supporting myself, and Associate Professor Joe Kemp, who you'll see on the bottom left there, and we've co-led the program. And then special mention also to Matt Francis and Karen Dungiles, who have been instrumental as research assistants. And then we have more than 30 tutors all around the country. And I guess the point of this slide is just to highlight that if you do want to change practice and implement exercise, you really need to think about bigger picture, and it takes such a big team, and it really takes a village essentially to make these things happen. So to give you an idea about some of the program outcomes, we published a program evaluation recently from around about the first 2,000 knee osteoarthritis patients. And we saw real-world improvements with GLAD, consistent or better than what is found in controlled clinical trials. And in simple terms, we saw 3 in 4 people report clinically meaningful improvements in pain or quality of life at 12-month follow-up. And those who did desire surgery prior to starting the program, 3 in 4 of them had not had surgery and no longer desired surgery at the 12-month follow-up. So we're quite impressed and very pleased with these findings. We're actually implementing what is guideline-based care and implementing it effectively in clinical practice. So I won't go through this presentation of the video here, but just to point out that there is a YouTube video associated with this patient story. And this is just I guess an example of a real world person who was about to have a joint replacement surgery, didn't have that joint replacement surgery because a cardiac condition was identified. This led them down the pathway of having cardiac rehabilitation and of course cardiac surgery prior to that, and then going into GLAD, and eventually went on to not have the surgery, get back to his quality of life that he had before with very minimal pain. He's actually getting towards 4 years since this case began, and still has no desire or intention to have surgery. So you can certainly have a read of that beyond today's session. So bigger picture, just to, I guess, round things out, we need to think about the barriers and enablers across the whole context. And I think if we talk through some quotes that come from people who are maybe going to access the program, so really strong considerations around costs being a key barrier. And this also emanates from surgeons and GPs who might be referring to the program. So these are really big things that we need to consider. So why don't more Australians currently access GLAD? Well, there's a lack of funding from private health insurers. Our Medicare system simply doesn't support it. And this is not unique to osteoarthritis. This is chronic disease across the board. Many Australians with osteoarthritis and health professionals are aware of the benefits. And as we talked about before, GPs are more likely to refer for things like surgical opinion and even prescribe things like harmful opioids. And this makes sense because there's actually health system funding to support this type of care, but very poor health system funding to support exercise and education. And I'll discuss this later. So take-home messages, a few key things. Many factors drive guideline practice gaps. Workforce capacity building is vital to improve the care of Australians with osteoarthritis. A structured program can help address the guideline practice gap, but the elephant in the room remains funding, and I look forward to chatting more about that in the future. For those who might be based in Melbourne in particular, if you do have patients, I'll just give a quick plug, or people within your friends and family and networks, both older than 40 and under 40, or interested in helping osteoarthritis education, please send us an email. Be more than happy to try and link up with some research projects that might be mutually beneficial. But thank you, and I look forward to some questions in a little while.